Onc Live Insights is a video editorial program produced by Onc Live.
The multidisciplinary team is very important in the management of a complicated situation such as a glioblastoma. These patients require the expertise of a variety of specialists. Often the first member of the team that's called in is a neurologist who evaluates the patient's neurologic symptoms and therefore orders the appropriate imaging. The diagnosis is made by a neurosurgeon who's doing the operation, and often that's the first person who is being called in to discuss the patient's disease, and therefore is the one that will be putting together this multidisciplinary team if there isn't already a neurologist on board. The neurosurgeon therefore will then amass a team that consists of a neurologist or a neuro-oncologist in a center where one is available. A radiation oncologist will be called in to perform radiation therapy on the patient. A medical oncologist, if the neuro-oncologist is not available, or depending on the way a center is set up, a medical oncologist will often be a part of this team as well to manage chemotherapy approaches. Social workers, nurse practitioners, physician assistants, rehabilitation medicine doctors are all a part of this team in getting the patient through their initial weeks of treatment. The additional people that may be added to the team, depending on the patient's particular needs, might include additional subspecialists, such as a neuro-ophthalmologist if the patient has visual challenges that are presented. They may require services of an interventionalist who may need to perform procedures on the patient, such as putting in filters if the patient has complications such as a blood clot. There may be infectious disease doctors who are pulled in. So really the net that is cast by this tumor in terms of the people that may be called in to see a patient with this disease is very wide, but the core members of the team include, in general, a neuro-oncologist, a neurologist, a neurosurgeon, and a radiation oncologist. In a patient with a complicated disease such as a glioblastoma, a multidisciplinary team is amassed, usually weekly, in the context of a multidisciplinary tumor board meeting. In those meetings, the relevant history is presented. The neuroradiologist will present the appropriate imaging for the team. The neuropathologist will review the pathologic findings, and then a multidisciplinary discussion will ensue to create for a particular patient the appropriate therapeutic approach going forward. In an academic center, often the patients will come from far away, and it's very important for these patients to coordinate care not only in the institution where the patient has their initial surgery, but where the patient may be having ongoing care. So in an academic institution, which is often a magnet for a rare and complex tumor such as a glioblastoma, we will reach out to the community physicians to help to coordinate care for a patient with this disease.
So when I encounter a patient who comes into my office with glioblastoma, there's a lot of things to get out on the table right as we're starting. It's hard to break the news, obviously, to the family that we've got something that looks very serious, that may be this horrible diagnosis called glioblastoma, but we need to know that up front for a number of reasons. First and foremost for myself as a surgeon is we need access to that tissue to make the diagnosis. We also use some of that tissue in our labs and in collaborators to help study the disease to figure out what we can do to make treatment better. But we also need to know beforehand whether the surgeon and the family think this might be a glioblastoma, because many of our therapies now require tissue. For example, some of the therapies involving cell-based vaccines like the dendritic cell vaccine. So we need to have this discussion often before surgery, before the pathologist makes their final diagnosis that they may have this horrible disease. When you're looking at glioblastoma, one of the most important prognostic factors is the age of the patient, as elderly patients don't do nearly as well as younger patients. What's called their Karnofsky performance level. So someone who comes in absolutely normal is 100, someone who has moderate disability is down to about 70, and someone who's hospital bound might be down around 30. Patients who are in better shape when they start tend to do better. And then the other important prognostic factors, aside from getting the standardized therapy these days with radiation and temozolomide, includes extent of resection.